Good morning. Uh, Thank you, Dr. Sendhil, for the kind introduction, and thank you for the KSMN candidate cardiology team for inviting me to this presentation. So you have listened to the acute STEMI and non-STEMI, the management, but the management is not over from there, and it has to be continued to prevent complications and recurrences and for the quick recovery. So the interventions, not only PCI, as the previous speakers mentioned, the patient sometimes goes to bypass, and we are not dealing only with the coronaries, we are dealing with the structural heart disease as well. And though we are cardiologists, and the team may be consist of both cardiologist as cardiothoracic surgeon, and I have a small part of thoracic, post-op thoracic care also here covered. And the source of information is from American Heart Association and American College of Cardiology, and ESC, European Society of Cardiology, and Cleveland Clinic. So the care after discharge, this should be planned before the discharge. So if you are talking after discharge management, it should be planned before. And this is not only pharmacotherapy, which consists of antiplatelets main treatment and statins, sometimes treating for other comorbidities like diabetes, hypertension, other coexisting conditions like anemia, CKD, etc. Because our patients not only having ischemic heart disease, it's a mixture of other problems. And there are some specific care to the case specific. Let's say if it is PCI, if it is ASD, if it is bypass, it's different, maybe different. And sometimes they might have scars, wounds, post-op wound care, and they might need physiotherapy, lifestyle modification, and not to forget the psychosocial aspect of the management, which is not addressed very well in our setup, or means generally in our country. But it's a multidisciplinary team approach should be there for this management, this post-op care. And the planning should be the clinic visits. How do we see the patients? How quickly we have to see, whether it's 1 week, 2 weeks, 3 days, 4 days. It all depends on the case. And sometimes we have to arrange home visits, but again, it's not practical here in our setup. But in other Western world, there are home visits by district nurses, and you might need to refer these patients for relevant specialty. Otherwise, you are managing only ischemic heart disease, and if you are forgetting about the other comorbidities, then again your patient end up with another event. And the most important thing is rehabilitation program, the cardiac rehabilitation, which is taken place in most hospitals where the cardiology specialty is available, and even in Kurunegala, I think it can be as well. And we have to plan. Sometimes our management is only stopped at one stage, and you might need another stage procedures later. So this is also has to be, you have to concern about these things as well. And the pharmacotherapy antiplatelets, now we have talked about lot about antiplatelets, so it should be continued for lifelong, mainly the aspirin. And but now Priyanka said that now he's more talking about clopidogrel, P2Y12 inhibitors. So there are still the guideline says the lifelong is aspirin. It could be after a medical therapy for your ischemic heart disease or acute coronary syndrome, or it could be after PCI, CABG. Sometimes we are giving after ST device closure for short duration. And the other important drug is anticoagulants. If it is associated with atrial fibrillation, or in certain situations like valvular heart surgery with mechanical prosthetic valves. So this is about aspirin, the answer for Dr. Charles Anthony Pillay. The stable coronary artery disease, and now we are doing a PCI for as an elective case or an acute case, right? If it is a stable coronary artery disease, the initial period, either whether it's DES or BMS, where BMS stands for bare metal, DES for drug eluting or drug coated balloon. If there's no bleeding risk, we have to continue. at least 6 months, right? Not this at least 6 months of dual antiplatelet, but usually it is for 1 year. But if it is acute coronary syndrome, if there is no bleeding risk, you have to think of continuing for 12 months, right? What about CABG? CABG is again a bypass. The dual antiplatelets has to be continued at least for 12 months. This green color is for class 1 indication, class 1 recommendation, right? So class 1 is we have to give these patients to be treated with dual antiplatelet unless there is a contraindication like high bleeding risk. Then your algorithm is different, right? And then there are guidelines, but you have to use your clinical expert experience to tackle these things, because different if you take 10 patients, they have 10 modes of bleeding risk or ischemic risk. So they have to weigh the benefit and the risk. So I don't know whether you can see here, this dual antiplatelet has to be given, can be considered beyond 12 months, right? Beyond 12 months, up to, it can go up to 30 months now, that trial, and now it has extended up to 39 months. So it means 3 years and 3 months, right? But it all if provided that your bleeding risk is very low. So how do you know your patient's bleeding risk is low? There are objective assessment of scoring systems like expert these DAP scores, precise DAP score and DAP score, right? So I'm not going to discuss in detail, but you have calculators to calculate that score. If the score is let's say precise DAP score is for bleeding and the DAP score is for bleeding, precise DAP score is for ischemia. So depending on the scoring, you can decide to what extent you are extending the dual antiplatelet, but with close monitoring of bleeding and ischemic risk. And again, after the bypass, it has gone beyond 3 months now, 3 years, 2.5 years. You can see this is algorithm in the class 1 for the 12 months, and it can go up to 30 months now, right? Even after bypass, if the bleeding risk is low. Some patients are with, as I said earlier, there is indication for oral anticoagulants like warfarin, especially patients with atrial fibrillation or patients with valvular heart disease. In that case, the triple therapy consists of dual antiplatelet plus one anticoagulant, oral anticoagulant agents we are using. Either it could be a traditional warfarin or a newer agents like NOACs, like apixaban, edoxaban, rivaroxaban, dabigatran, etc. But for the mechanical valve, still the warfarin is the drug as an anticoagulant, and for the atrial fibrillation, you can use the NOACs. And the triple therapy, again, Dr. Priyantha said it's 1 week. Yes, beyond 1 week, the risk is bleeding is high, but the guideline says you can go up to 1 month, right? If the bleeding risk is very high, you don't consider 1 month even. You are starting with dual therapy. Dual therapy means not dual antiplatelet, one single antiplatelet plus oral anticoagulant. C stands for clopidogrel, O stands for oral anticoagulant. If it is bleeding risk is low, you can consider beyond 1 month, and there is a shaded area here. Within 3 months, you can decide on whether you are going to stop triple therapy after 6 months. But earlier the better if you can stop. But the ischemic risk is very high. Then you have to consider triple therapy with caution, with close monitoring. But beyond 6 months, dual antiplatelet, and after 12 months, it's only oral anticoagulant agent, right? This is now you might have seen even us cardiologists doing this. Patient is on one anticoagulant and either aspirin or clopidogrel even after 12 months for years and years. But according to the guidelines, it is not advisable because the benefit comes low and the risk is going up. The bleeding risk is going up because you are just anticoagulating without an indication, because by this time your stent has been endothelialized. Your stent is not exposed to the lumen, and the grafts are very well endothelialized. The graft patency is maintained, so oral anticoagulant is only enough. Mind you, this is I am talking about if there is it is combined with, if there is indication for oral anticoagulation, right? Now for others. So we have to plan this monitor in INR, check for over under anticoagulation and follow-up because are sometimes important, certainly in valvular heart diseases. Then the statins. The statins, now we have started statins and we have to continue. Long-term statins. It's long-term. The studies are up to 75 years of age. The guidelines and the trials, most of the time, this study population consists of 18 years to 75 years. So because of that, it says long-term. Depending on the other contraindications or complications like let's say liver transaminases issues or myositis, then you have to reconsider about your dose. Otherwise, they should be on high intensity statin. High intensity statin is very important because we have seen even our colleagues, our medical officers who are doing managing patients in the hospital, out of the hospital, or other clinicians tends to they have very fear of giving these statins because of these AMT issues and CPK issues. But always you can monitor if you want, but always consider if there's no contraindication, high dose statins, because the normal statin dose, the 5 milligram, 10 milligram is enough to come down your blood cholesterol level. But the problem is not only the blood cholesterol level, it is the cholesterol plaque inside your vessel, that in the media, the wall, the vessel wall, coronary arteries. So the plaque formation, we have to suppress the plaque formation, and we have to regress the plaque, and it has a lot of pleiotropic actions, and it has shown that these effects can be achieved only with high doses statins, right? So it's called high intensity statins. Imagine now your patient is on 20 milligram of rosuvastatin or 40 milligram of atorvastatin, and your LDL is about 30 and 40 is very low, and total cholesterol is about 110, 100. So now patient will ask, can we reduce the dose or can we stop the statin? The answer is no, because to keep that level, to the lower the better, lower the LDL is better, the low atherogenic. Then to keep it low, you have to maintain that amount of statin, that dose. So that's maintained with that dose for that. If you reduce the doses, again it will start to work, right? And other drugs, excuse me, we have to consider is beta blockers we discussed earlier, and the ACE inhibitors. The answer for the again Dr. Charles, I have not written here ARB because ARB is the second option, either ACE inhibitors or ARB. And mineralocorticoid receptor antagonist, that's spironolactone, eplerenone, in situations like MI with diabetes in EF E150 or MI with EF less than 35 or 40, we have to consider spironolactone, and proton pump inhibitors, etc. But the newer drug is empagliflozin or other gliflozins, SGLT2 inhibitors, and this is not still in the guidelines as an essential drug, but it has shown a lot of promising effects to consider in patients this drug package. I mean the discharge or the continuing drugs, right? And we should not forget other comorbidities as I discussed earlier. Few words about how a patient should, after going after ASD device closure, again an intervention, maybe not coronary. Here the DAPT we are giving for 3 months, aspirin and clopidogrel mainly. 3 months, and then you can continue aspirin for 6 months, another 3 months, that means another 3 months. And during this time, we think that the device is exposed to the cavity, the blood, it touching the blood, so it has to be endothelialized. It takes some time, and this takes about 6 months, and during this time you have to give endocarditis prophylaxis as well. And you need follow-up echoes in 1 month, 3 months, and 6 months, and not forget before discharge as well. Right? So these patients are managing like that, and after 1 year you can repeat echo. Most of the time, device closures no need further evaluation unless patient having symptoms like pulmonary hypertension, borderline pulmonary hypertension. For severe pulmonary hypertension, we don't do device closures or the surgical closure. The most important post-op care is the cardiac rehabilitation, which is an objective, very well planned, validated program, and it has guidelines, and it's scientifically it's validated, and it has shown the cardiac morbidity and mortality and recurrent hospital admissions. So these are the forgotten part in our management. In a hospital setup, we always more focus on acute management. We get some satisfaction once we put a stent and nice flow and right good results. Patient is pain free, but we forget the post care. So this is very important. Otherwise, patient's recurrences will be very high if you forget about rehabilitation. The phase 1 rehabilitation starts within the hospital, and it consists of all these cares I'll come to later. And the phase 2 is post-discharge pre-exercise, and phase 3 is exercise and education program, and phase 4 means maintenance lifelong. That is done by patients unknown, not as a program. So phase 1, 2, 3 is in rehab program, and phase 3, by the phase 3, the interest of the patient it coming down. It has shown that only 30% of patients will come to at the end of phase 3 cardiac rehabilitation, because it takes time, years, to come to this phase, months to years. So few words about phase 1, though this is my topic is after discharge, but I want to highlight about that, otherwise I can't go to the phase 2. So this is a multidisciplinary team approach, as I said earlier, and the patient exercise capabilities will be assessed. The less strenuous things like sitting up of the bed, getting off from the bed, and walking with the aid, with the support, has to do during the initial stage after intervention, or mainly after bypass procedure, right? And the patient should be given education about the risk factors and the diagnosis, and a lot of emotional things can going on inside his mind, because he thinks this is his end of the life, and he can't believe what has happened, he can't imagine, he's clueless, and he must need a lot of emotional and social support. And again, relevant referrals has to be done in the phase 1, and this will benefit in decreased length of hospital stay if you address even phase 1 while in the hospital, this patient while in the hospital, the rehabilitation, and this will improve the patient satisfaction as well as the clinician satisfaction, right? And other staff satisfaction, and again, as I said, decrease readmissions, these things, right? The phase 2 begins after patient leave the hospital. So we have to plan before the discharge about this rehab program, and it has been dealt with physical activities, the nutrition, stress management, psychosocial aspects, and other health related issues, and this pharmacotherapy as well, and patient education. They are doing ECG monitoring on each session, and in the clinics, when you see the patients in clinics, let's say patient is not coming to the rehab but clinic, you have to go through very quick in the first visit the history examination relevant to the cardiac things, whether he has had angina is settled or whether recurrent angina, and what is his blood pressure, heart rate, whether he's tachycardic. All those things to be assessed very thoroughly in first clinic visit, then subsequently you can monitor in the subsequent clinic visits. The benefits of phase 2 is it decreases the chances of another cardiac event, improves stamina and the confidence and well-being, and it reduces patient symptoms, and we have to individually plan the treatment for different case scenarios. Phase 3 is, as I said, it's 30%, only 70% will be drop out at the end, and patients more self-independent and more independent doing self-exercise, and very few patients will be following this stage because now their fears has gone. They are doing their own normal living lifestyle, and now they are forgetting about their previous bad experience with the disease. Just they continue the medication. The post-care specialty specifically related to the intervention of post PCI, it's depend on the elective or emergency, right? And some activities can involve there, like let's say driving, exercise, let's say having a bath. The people have these questions. So these things, some things, the CABG takes some more time to recover, but PCI very quickly recovers. So the more or less it's same, but only the starting point is different. So we have to look for complications in your clinic visits patients. Sometimes you might not detect these complications when you are discharging the patient, especially the puncture site complications. The post PCI, either it could be radial or femoral. You can get this kind of pseudo aneurysms at puncture site, and shows these aneurysms, and the Doppler study here, and the lump here, right? And I have come across one of my patient whom I have punctured in a private sector, came with a arteriovenous malformation, AVM. Patient said she's feeling some vibration feeling here. So when I touch, I feel the bruit, and I oscar the bruit, and there's a thread. And then the vascular, I did a vascular referral, and we saw a malformation, and it has been ligated. It's a small AVM, but it can happen even for a radial artery puncture when it is go through and through. And the femoral artery puncture, it's more complications are more common than the radial artery. This is not uncommon. We see the hematomas, subcut hematoma, subcutaneous. Sometimes they will have, this is a true aneurysm and this is a pseudo aneurysm, where the only the adventitia will go up. There is no true aneurysm. Here you can see the cross section, right? Then sometimes this can be ultrasonically, we can suppress with the pressure, or sometimes you might need surgery, or the newer techniques like thrombin injection can be done directly to this aneurysm, pseudo aneurysms, right? So these are some complications you might come across, but these are not grave. And there's an immediate complication can occur in this femoradial puncture, sometimes compartment syndrome, but that will be detected most of the time patient is getting discharged, before the patient is getting discharged. That's occur more early and acutely. And a few words about post-CABG care, though this is not my specialty, but for the sake of interest I have written, because it's an again intervention. And the incision, some patients comes with the sternal car inflammation features like drainage, oozing from the incision, increased opening of the incision line, and redness, warmth, etc., and fever sometimes. And it can also happen at graft harvest site on the leg, saphenous venous graft. Same complications can occur, and not a big issue can be dealt by the cardiothoracic surgeon or even a surgeon. And the long-term complications are sometimes keloid, and due to the lymphatic obstruction while harvesting the saphenous graft on the leg, they can get lymphatic edema. So this is a troublesome complication because it will take long to settle, or sometimes it's not settled at all, and patients will end up with recurrent cellulitis. Shower and bathing. After a PCI, there is no contraindication. At even discharge, you can have a shower after PCI. It all depends on whether the patient is having low ejection fraction, other comorbidities, patient is bad, sepsis, things. If it is clean, problem with just only cardiac and nothing, no other issues, yes, you can have a bath before discharge. But if patient is having a CABG, it might take 1 week, right? And the direct spurt of water to the skies better avoid, and keep the incision clean and dry. And you recommended use soap and water, not this body wash or the shower gel, etc. Right? I don't know the reason. That is clearly said in Cleveland Clinic post cardiac CABG management plan. The pain control is very important, because when the cough, if pain, if it is, we can control pain very well. Patient can cough out secretions, and no stagnation of secretions, and it prevents pneumonia. Right? Then patient will walk early, and breathing exercise can be done very easily. And it is very essential, this breathing exercise, to prevent pneumonias, as well as increase recovery, clear the lung areas, and reduce pneumonia as well, because of the wound, the patients breathing with very difficulty, so they will have exposed to a lot of pathogens in the hospital, so high chances of pneumonia, we have to prevent that. So this is called 3-ball incentive spirometer or respirometer. It is actually not exhalation, it's a inhalation, inspiration exercise, right? You have to take a lot of air into the lungs to go this ball out. And some surgeons prefer to give this post-thorax vest. Some are not. There are pros and cons. But if you are wearing, you should wear all the time. And it's actually with the advice of the cardiothoracic surgeon. The diet and activity, it's a very big topic. It's a secondary prevention of cardiac disease or any other metabolic syndrome. For here, the special things are for a patient who has undergone bypass. We advise to take small and frequent meals, avoid heavy meals, because your diaphragm will push up sometimes and is feel uncomfortable, and breathing might get difficult, and recovery will be delayed. And most of the time, the plan is given by a nutritionist before discharge. Alcohol. What about alcohol? The other question patient will ask in the clinic, whether I can take small amount of alcohol, body shot the beer like that. The general advice is avoid alcohol. There are things favor of coronary artery disease, but general advice is avoid alcohol. Some patients already maybe patients who are alcoholic might undergo these procedures. If you are planning and do, we have to give alcohol withdrawal treatment before bypass or intervention. Otherwise, you end up with problem situations after the procedure. Right? What about sex? Better after 6 to 8 weeks. Keep in mind that the sexual relationship is both physical and emotional, and we have to talk openly with the partner, and gradual return of sex, and the amount of energy is required to perform a sexual intercourse is similar to climbing about 1 or 2 flights of stairs, or walking about 1.8 kilometers at a brisk pace. So if you are able to do that, you don't need to worry. But it's again, remind you, it's a gradual process, and it's a you have to discuss with your partner. Driving. In driving, we don't have a clear-cut thing like DVLA in UK, but the science behind this is sternum healing usually takes 6 to 8 weeks, and the patient's ejection fraction could be different. Some patients ejection fraction 60, some ejection fraction 20-30. So we have to assess differently. If let's say a patient who has undergone bypass in Sri Lanka, we ask them to go for subjected to a exercise stress test in 3 months time, and whether if it is okay, then we approve him for a driving. Let's say especially it's important in passenger transport, buses and 3-wheelers, and light vehicle driving you can start earlier than that, but again it's always better to see after about 2 months. Return to work, again depending on the patient's ability, the type of work. So it has to be assessed by occupational therapist before discharge. And for a bypass, in current practice, if the patient wants leave, he or she is entitled to take 6 months leave, but has to undergo a medical board interview. So lifestyle modification, I'm not going to talk everything. And we have the diabetes, the relevant problems we have to be dealt, and the smoking. One other thing I would like to emphasize: cigarette smoking is responsible for 50% of all avoidable deaths in smokers. Half of this due to ischemic heart disease. A lifetime smoker has a 50% probability of dying due to smoking. So these are a lot of things of smoking, and prolonged smoking is hazard. So smoking is never ever advised and has to be stopped at any cost. And even second-hand smoke, that means passive smoking, is not good. Even that electronic smoking also not advised. Right? Alcohol, these are because of the time factor I just rushed through. Again, this says the alcohol, the safe limit also better to avoid, because some studies shown that more Mendelian randomization studies do not support the apparently protective effects of moderate amount versus non-alcohol. So better to avoid. Not to forget about psychosocial factors, the most forgotten thing in our practice. So these are the reference, and thank you. This photograph was taken 2 weeks ago at Belihulloya, beautiful sunrise in Sri Lanka, one of my hobbies. Thank you.